Okay, here is your timer and here is your question. Right, if you have read and understood, kindly help me and identify the structures. What are you looking at? Can you tell me first?
This is the anterior part of the abdomen.
Yes. Can you tell me how anterior abdominal wall is formed?
There's three muscles: external
Okay.
oblique muscle, and internal oblique muscle, and the transversus abdominis, and also there is the rectus abdominis muscles.
Okay. Can you
And the
identify, yes, please, structures from A to G?
A, this is the linea alba,
Yes.
and B, this
What
is
is linea alba?
this fibrosis epinuresis that formed from the three muscles, the
Okay.
external and the internal and transversus abdominis, which converge at the midline.
Yes. And it's
B, this is
relatively avascular and it's ideal for
avascular.
incision without bleeding. Okay.
Yes,
And B is?
the tendinous intersection.
Yes.
And
What
C, this is
is tendinous insertions?
the during development where the
Yes.
myotome uh,
Yes. We'll revise. Okay. Next, C,
okay,
please.
this is the external oblique muscle.
Yes. And D,
D, this is
please.
the rectus abdominis muscle,
Very
and
good.
E, this is uh, superficial epigastric vessels,
Yes, very good. It's pointing here.
and
E, yes. Yes. And F, please.
F, this is the umbilicus, and G,
Yes.
this is the anterior layer of the rectus sheath.
The posterior layer. Okay. Tell me
Okay,
where this rectus sheath ends. How is it formed?
there is anterior sheath and posterior sheath, which
Yes.
is joined by the linea semilunaris. It
Yes.
is end just one third below the umbilicus,
Yes.
which where there is the arcuate lines. This is demarcates the lower end of the rectus sheath.
Okay. Can you please tell me the sequence from skin to the peritoneum if incision is made at transversely at the umbilical part?
Okay, there is the skin and subcutaneous tissue. There is the scarpus fascia, and there is the cicatrix pillar scar, and there is the
So there is
parietal
skin,
peritoneum and
subcutaneous.
extraperitoneal
Yes.
fat.
Which fascia?
Scarpus fascia.
Yes. And then?
There is the gastric pillar scar, and there is the
Yes.
extraperitoneal fat and the parietal peritoneum.
Very good. Okay. Can you tell me how external oblique muscle is formed?
Okay, it is the origin from the lower eight ribs to be inserted in the linea alba and
Yes.
in the iliac crest and pubic tubercle, and also it is inserted into the anterior superior iliac spine, and this forms the inguinal ligament.
Okay, at the bottom. Yes. Can you please tell me what is the significance of arcuate line and what is the surface marking of it?
This is defines the lower limit of the posterior sheath of the posterior layer of the rectus sheath. This
Yes.
can be found one third between the umbilicus and the pubic tubercle.
Okay, good. Can you tell me what is the median umbilical ligament? Where is it located and what does it contain?
It can be found between the bladder and the umbilicus.
Yes.
It is resembles the remnant of the allantosis or the oracles, which
Yes.
drains the urine
Yes.
during development
Yes.
to the umbilical cord.
Okay. What happens if it fails to obliterate after birth?
There will be draining of the urine to the abdominal cavity.
Okay. What can you tell me where are the medial umbilical ligaments are located and what do they contain?
Just lateral to the medial umbilical ligament and it
Yes.
contains the remnant of the umbilical artery.
Yes. And they are in the deep surface of anti-abdominal wall. Okay.
Yes.
Can you please identify this picture, these structures, please, from A to H?
Okay. This is the right renal artery.
Vein.
E, vein. Okay.
Because it's, yeah. Okay, and
This is
then B.
anteriorly. Yes. This is the vein. This is inferior vena cava.
Very good.
And C,
That
this is
that's why if you'll pay attention, that's why it's vein, right?
yes,
Vein
yes.
and then inferior vena cava. And then C, please.
This is the right gonadal vessel.
Yes. And D, please.
And this is the left suprarenal gland.
Yes. E.
This is the superior mesenteric artery.
Yes. F.
And F, this is the left renal vein.
Yes. Very good. G.
E, this is the abdominal aorta. And
Yes.
H is
H.
the left ureter.
Can you please tell me what do you understand by the term ligament of Treves? From where to where does it connect?
Uh, ligament of the teres, it is, can be found at the liver.
Do you know
The
general
inferior
connection
surface of
to
the liver.
diaphragm? What's its significance?
Okay.
Commonly, it's cut to access aorta. Okay.
It's
Can you please tell me the branches of abdominal aorta?
okay.
All of them.
Okay. There is a celiac trunk and superior mesenteric artery, and there is a inferior mesenteric artery
Yes.
interiorly,
Yes.
and
The lateral
laterally
branches.
there's
Yes.
the left and the right renal arteries, and there's the gonadal vessels,
And there is one more before renal.
and also there is the lumbar arteries and the medial
Suprarenal.
sacral artery and
Suprarenal
suprarenal artery.
also.
Okay.
Okay. And the lumbar and what? Which one?
The median sacral artery.
Yes, but then there is inferior phrenic as well, and there are two commonly the terminal when it divides. Okay.
Yes.
Can you please identify the structures on the left hand side from A to K, I, L maybe?
Okay. A, this is the abdominal aorta.
All right, good.
B, this is the right common iliac artery, and
Yes,
C is the left common iliac artery, and
yes,
D is the left renal artery, and E
yes.
is the right renal artery,
G.
and there is F, this is the splenic artery, and G,
Okay.
this is the common hepatic artery,
Yes, H.
H, this is superior mesenteric artery, and L, this is the inferior mesenteric artery,
I.
I, this is the gastroduodenal artery,
Yes,
and there is the
J.
J and K, the right and the left hepatic artery.
Okay. And J and then L. Inferior
The
mesenteric
inferior
artery.
mesenteric artery.
Very good. Okay, on the right hand side, you can see some structures. This is okay. You can already imagine this is aorta and this is inferior vena cava. Here is
Mm.
one structure marked. Can you identify that structure?
The right gonadal vessels,
Yes. What is its relation to ureter?
just anterior to the ureter.
Okay, good. Very good. Bell has gone. What else? What was the other topic we had to cover with you?
The inguinal canal. And
Yes,
also,
can you tell me how is it formed?
okay, there is the boundaries. Anteriorly,
Yes,
there's external oblique aponeurosis, and laterally the internal oblique aponeurosis. Posteriorly, there's
yes,
the transverse fascia and the conjoint tendon.
yes.
At the roof, there is the internal oblique and the transverse abdominis. Inferiorly, there is the inguinal ligament and the lacunar ligament.
Yes.
Also, laterally, there is the external ring and the internal oblique muscle and the transverse abdominis. Medially, there is the internal ring and the conjoint.
Okay, what are the contents of the femoral triangle?
Uh, 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 Inguinal contains the spermatic cord
Oh,
and also
I'm
the
asking about the contents of femoral triangle.
femoral.
Yes. Okay, you only want to talk about inguinal canal. Is What is the normal length of inguinal canal in a human being, irrespective of gender?
Uh, about 3 centimeters. I don't was
4 centimeter or something. Yes. What are the contents of inguinal canal?
it contains the spermatic cord
Yes.
and the
In case of
ilioinguinal nerve.
male. Yes.
Yes.
And in case of
I think
female?
the female is the round ligament of the
Yes.
uterus.
Very good. Okay. Right. Inguinal canal can be. What are the pathological significance of this canal?
There is can be inguinal hernia passed through the deep inguinal ring.
Yes. What does it call when it passes through deep inguinal ring?
Indirect inguinal
Okay, it's common in which age group?
cone in elderly.
Yes. And what is the management when it occurs?
Uh, just surgical hernioplasty and herniorrhaphy.
Okay. Could there be any conservative management that you can offer?
Uh, we can avoid lifting heavy objects and we can use thrust.
Yes. Good. Thank you.
Thank you.
I'm starting the timer, and here is your question. Right. If you have read and understood, kindly begin. And considering it critical care station, tell me how would you manage this patient? And what would
Ma'am,
be
should I
your,
tell the
yes,
diagnosis first?
yes,
Okay.
please. What would be your
Okay, yeah.
provisional diagnosis? Yes.
Ma'am, my diagnosis on the background of the history that you have provided me is a gastric outlet obstruction, which
Yes.
has been which basically showing the sign of hyponatremia currently because of the profuse vomiting. I'll
Yes.
managing the patient. First, I'll start resuscitating the patient. Uh, two large bore IV cannulas, sending this urine
According to
for
what
the electrolytes.
protocol would you manage your patient?
Ma'am, I'll manage the patient according to CREST protocol.
Yes.
Two large bore IV can after making sure the ABCD is in line, the patient has adequate airway, breathing is fine, the circulation, two large IV bore cannula, and
Yes.
starting the patient on the sodium chloride. Along with the once the resuscitation has been done, the patient has the adequate urinary output. Then I'll start with the potassium supplementation, and
Yes.
I'll make sure that I'll monitor the urine output. Along with that, afterward, I'll take the detailed history examination, and if the patient has been, and I'll take a look on the input-output charting and all the labs that has been done before.
Yes.
And afterwards, I'll do the nasogastric decompression, passing the NG tube, and the catheterization, and I'll monitor the output from both.
Yes. What type of metabolic alkalosis patient can have?
Yeah, ma'am, this is basically a hyponatremic, hypochloremic metabolic alkalosis, hyponatremic, hypokalemic metabolic acidosis with paradoxical aciduria.
Okay, can you tell me what is the pathophysiology which lies behind it? How does it
Ma'am,
occur?
first of all, okay, there is a profuse vomiting which leads to lots of acids in the vomitus that will lead to dehydration and the metabolic alkalosis, due to which the kidney will try to counteract it and start excreting more and more bicarb, and this will, on the background of dehydration, will lead to the increased secretion of aldosterone, which will activate the sodium hydrogen and sodium potassium pump in the distal tubule and cortical collecting tubule, which will lead to the increased algines and the potassium excretion in the urine, which will manifest as a paradoxical aciduria and the hypokalemia.
Can you name few causes of gastric outlet obstruction?
Yes, sure, ma'am. Either the benign or the malignant one. In the benign, it
Yes,
could be secondary to the chronic peptic ulceration that have led to the stenosis, or it could be a duodenal web or the gastric polyp. And in the metastasis, it could be secondary to pancreatic carcinoma or the gastric carcinoma.
very good. Can you name few symptoms that you should look out for?
Ma'am, the patient will present to me with the complaint of inability to will have the complaint that he cannot have a adequate amount of the food, and once he take it, start vomiting it out, and the vomiting is a profuse amount, and along with that there would be a gastric fullness that he will feel, and on the examination I can see the succession splash either on jolting the lumbar, jolting the abdomen, or either sometime without it.
Okay, can you please tell me why the patient has hyponatremia?
Ma'am, because what happened is there's a loss of acids, and in order to due to which there is a metabolic alkalosis. For this metabolic alkalosis, the body will try to excrete the bicarb. So bicarb excretion is basically accompanied by the sodium. That's why the patient would have the hyponatremia.
Is it possible for you to classify hyponatremia with examples?
Yeah, sure, ma'am. Ma'am, hyponatremia can be first classified on the basis of the tonicity of the plasma blood, either the hypertonic or hypotonic. In hypertonic, basically the main cause could be pseudohyponatremia, which could be secondary to hyperlipidemia, multiple myelomas, these conditions. In isotonic, it can be secondary to syndrome of inappropriate idiot release, which would be the delusional one. In hypertonic, we have the three things: hypervolemic, hypovolemic, and euvolemic. In hypervolemic, we would have the patient would have the cirrhosis of liver, congestive heart failure, kidney failure. In hypovolemic, we would have the patient nausea, vomiting, burn, ARDS, post-op patients.
Can you tell me or name few complications that can result as a cause as because of hyponatremia?
Okay, ma'am. There could be constellation of sign and symptom. It will start with the letharginess, irritability, and can be followed till confusion, seizures, and ultimately coma.
Okay, good. Coma and death. All right. Can you tell me why the patient is also hypokalemic?
Ma'am, because there's a dehydration and the loss of sodium, which will lead to the increased activation of aldosterone, which will going to activate the sodium hydrogen sodium potassium pump. This will lead to the increased potassium excretion in the urine that will lead to the hypokalemia.
Very good. Okay. Why do you think is creatinine and urea high?
And that is more likely to be the prerenal failure that is due to dehydration.
Yes. Okay. So why bicarbonate would increase? What is the mechanism behind it?
Okay, the first thing would be there's a loss of acids, and secondly, because of the decreased acid going in the duodenum, there is a less gastroenteric reflexia. There would be decreased secretion of the pancreatic rich bicarb fluid, which would lead to the retaining of the bicarb in the body, and that would give you the picture of increased bicarb in the blood.
Increased. I think you're telling the opposite. Okay. Why do you think patient has got paradoxical aciduria?
Ma'am, that is because of the same mechanism. Because if there's a decrease in sodium and aldosterone gets activated, it will activate the sodium hydrogen pump and the sodium potassium pump in distal tubule and cortical collecting tubule, which will lead to the hydrogen excretion and the
Yes.
potassium excretion and the sodium absorption. So that's why instead the patient had the metabolic alkalosis, patient is still excreting the HIs and the acids in the
Who
urine.
would you involve in the management of this patient?
I'll be involving the internal medicine doctor. Along with that, I'll be involving in the general surgery.
And
Um, no,
where would you manage this patient? Patient
I'll
has
be
arrived in
managing.
A&E. Yes. What would you do
Uh,
next?
Ma'am, I'll be managing the patient according to HDU, and I'll get other investigation done in order to know what is the cause behind it,
Yes.
along with the baseline that I have sent, such as CBC, UC, LFT, PT, INR. Along with that, I'll get the ultrasound abdomen done. If I am thinking about it to be a benign cause, the ultrasound abdomen would be giving me a bit provisional diagnosis. If I am thinking about some extra gastric thing, I might have to get the CT scan abdomen done, or might be ERCP as well.
So, do you think if the patient does not gets managed with conservative management and you need to do the surgery, when would the patient be fit for the surgery?
Ma'am, first of all, in order for patient to be fit for surgery, he has to have all the in order to undergo the general anesthesia, patient need to have all the blood parameters are within the normal range.
For how long? That's what I'm asking.
Like, ma'am, you should resuscitate the patient like at least for 24 hours.
Okay. So within 24 hours, you think you can manage the patient and patient will be fit for the surgery.
If his urea cred becomes normal and comes to the baselines.
Very good. Okay. Right. Good.
Thank you.
Thank you.
You're welcome, ma'am.
Okay, because there is loss of chloride. To maintain the electrochemical neutrality, bicarbonate will be absorbed more in renal tubules,
Yes.
not secrete, but absorbed. And second thing, there will be no acidic stimuli in the duodenum due to the loss of acid through the vomiting. So the pancreatic secretion will be reduced.
Yes.
And so there will be reduced secretion of bicarbonate in pancreatic juice that will also cause retention of the bicarbonate.
Yes. Good.
Okay.
This is the two main mechanisms.
Behind it. Yes. Very good. Thank you.
Yeah.
Okay.
Starting the timer, and here is your question. Right. If you have read and understood, kindly begin your examination.
Okay. After entering the room, I'll wash my hands and introduce myself to the patient.
Yes.
I'll confirm the name and age of the patient.
Yes.
Then I'll take the permission from the patient to examine his chest. That will include the looking, feeling, and listening of the chest and examination of legs and hands also. I look for any medication he's taking or any oxygen he's using or any charts is there. And then I'll ask the patient to get position in semi-sitting position. And I'll start by taking a close look to the patient's legs for the presence of any edema. And then I'll ask if he has any pain in the legs, and I'll Then I'll feel the leg for any calf muscle tenderness. After that, I'll see the hands of the patient for presence of any tar staining, any clubbing, presence of any tremors. I'll also see the radial pulse. Then I'll ask the patient to look towards the left side, and then I'll take a close look to the neck veins for any raised JVP. I'll also feel the trachea and the position of the trachea, if it is central or not. And then I'll ask the patient to open the mouth and stick out the tongue and keep it up. And I'll look for the central cyanosis, if present or not, and dehydration, and also look for the oral hygiene. After that, I'll ask the patient to lower his lower eyelid so that I can see if there is any pallor present or not. Now, I request the patient to take off his gown, and then I'll ask him to put the hands behind his head. I'll take a close look to the chest from the front, from the side, and from the end of the bed for the presence of any scars, or look for the chest shape. I'll count the respiratory rate. Then I'll go for feel the patient's chest expansion by placing my hands on the chest below the nipple. I'll wrap my fingers on either side of the chest and keep the thumbs together in the midline. And then I'll ask the patient to take a deep breath and see if the thumb is moving equally on the both sides. After that, I'll ask the patient if he has any pain in the chest before I'll start the tapping the chest. I'll percuss the supraclavicular, infraclavicular, chest wall, and axilla. I'll compare on both sides to look the presence of any resonance, dull or hyperresonance. And after that, I'll auscultate the chest from the front. I'll ask the patient to take a deep breath, and I'll put the stethoscope on his chest. Then I'll assess the quality of the breath sound as well as the volume of the breath sound, and also listen for any added sounds. I also assess the vocal resonance. I'll ask the patient to say the 99, and I put the stethoscope on the chest again. And then after that, I'll ask the patient to sit, and then I'll examine the patient from the back by looking, feeling, and listening the back of the chest at the suprascapular, interscapular, and infrascapular area, comparing on both sides. After that, I'll also feel for the lower back for any presence of sacral edema. Then I'll ask the patient, I'm going to look for, feel for the cervical lymph nodes. And I also look for any supraclavicular lymph nodes. And then I'll thank the patient. I'll help him to put the gown and ask the patient if he needs any help. Then I'll wash my hands. And to complete my examination, I would like to do the cardiovascular examination of this patient. Okay, then today I have examined a 57-year-old man who is a chronic smoker, and patient on examination, patient has presence of central cyanosis. He has a barrel-shaped chest, and the expansion of the chest is equally on the both sides. Bilateral, there is a hyperresonance, and also the air entry is bilaterally equal. There is a harsh vesicular breathing sound, and also there is presence of expiratory wheeze, but the vocal resonance is equal on both sides. Then my provisional diagnosis of this patient is most probably as chronic obstructive pulmonary disease because he's a chronic smoker. But I also considered the presence of any bronchial asthma and other diagnoses like pneumonitis.
Good. So who would you inform about the patient?
If the patient is scheduled for elective surgery, I will immediately inform the anesthetist and the operating consultant regarding the cancellation of this case.
Okay, what other investigations would you ask for this patient?
For this patient, I'll arrange for the chest X-ray, PA view, and the spirometry. I'll also advise for respiratory function test, and I'll also arrange for a baseline arterial blood gas analysis.
So how would you try to reduce the risks in a patient with COPD? who is about to go undergo surgery?
If the patient is before the surgery, I'll advise for the optimizing the medication for the COPD patient.
Yes.
Then, if required, we can refer the patient for respiratory medicine consultant.
Yes.
Then I'll treat any presence of infection before scheduling the patient for surgery.
Yes.
If patient is a smoker, I will do the cessation of the smoking, advise the cessation of the smoking. Also arrange the chest therapist before and after the surgery to encourage the excretion of excess mucus. And I'll arrange the bed in HDU. I will liaise with the HDU resident or HDU registrar to arrange a bed if the patient need post-operative intensive care. And I'll ask for the open surgery rather than the laparoscopic surgery, because in laparoscopic there will be pneumoperitoneum, which can compromise the respiration also. And I'll ask for arrange for the regional anesthesia and not general anesthesia.
Good. Any other advice? Patient is also hypertensive.
Yeah, I'll also refer the patient for medical specialist to arrange for to the treatment for the hypertension. And if he's taking antihypertensive drug before, then I'll arrange for that also.
How would you make sure patient has compliance for the antihypertensive drugs?
For antihypertensive drug compliance, I'll make sure that the drug is regimen is simple so that patient can take it regularly, and then patients should be followed up regularly in the OPD. And
For how
I'll
long do you
also
plan to follow up the patient before patient can go for surgery?
before at least I think 4 to 6 weeks before
Good.
the
Yes.
patient can be, yes.
Yes. Even I think so. I agree with you. Now, once 5 seconds were left, so I thought, why not ask a simple another question?
Yeah.
Very good.
Sure,
Thank you. Very good. Excellent. Yes.
Thank you,
Did you
ma'am.
remember to examine from the back?
Yes. Last I told that
yes, I think you did, but
I asked the patient
sure.
to sit. Yeah,
Yes.
I asked the patient to sit from the semi-sitting position, and then I had to examine from the back
From
with
the back as well. Yes.
yeah,
This I
inspection,
wasn't sure.
percussion,
Yes.
and auscultation. Yes.
Yes, and auscultation as well. Good. Good. Thank you. Here is the question. Right. If you have read and understood, kindly begin your station.
Okay. Yeah. Hello. Uh, good. Good evening. I'm Dr. Sunday, one of the surgical doctor. Are you mother to the dad that was brought in?
Yes.
Hello.
Doctor. Good evening. Yes, doctor. Good
Good
evening.
evening.
Yeah,
So,
actually, I was in the school, doctor, when I got the news that my daughter got some problem and my neighbor brought her to this hospital. I'm really sorry that I was not here for her. I'm really sorry. I'm feeling very guilty. I was at work, I could not manage. And she earlier had pain also, and I could not get her on time to the hospital.
I'm so sorry about your daughter. And I understand it must be hard, but I can assure you now your daughter is in a safe hand. So before we continue, can I just ask, so what have you been told so far about your daughter?
Doctor, when I come here, someone told me that my daughter got appendicitis. I don't know. Are you really sure that she got the acute appendicitis?
Okay, that's fine. So, like you said, she has a acute appendicitis. So basically, what happened is this: one of our teachers brought her from school to the ER, and we after examining her, and we did run some tests, so we discovered that she might be having an acute appendicitis. However, for us to be sure, only after operation, during operation, that we can be fully sure that it is acute appendicitis. And but currently, we've tried to stabilize your daughter. So we've given her some medication like antibiotics, and we've given her fluid also to stabilize her. And now she's about to go to the theater for operation. So and Mr. Ladd is the surgeon that's going to be operating your daughter.
Doctor, is it dangerous for my daughter? This acute appendicitis, you told, is it very dangerous to my daughter's life?
Okay, I understand your concern. So this acute appendicitis, so it means an inflammation of a part of a gut called the appendix. It's a small, tiny outgrowth from a gut, so which got inflamed. So, and that's what we call an acute appendicitis. Are you with me? So basically, so when we say this thing inflamed, that means it got swollen and infected. And if we didn't treat that early, or if that part is not removed early, it could get swollen and swollen until it ruptures. And that rupture can lead to a further spread of infection that could be dangerous, to our life. So, and that is why we need to remove the appendix as soon as possible. Is that clear?
Yes, doctor. You told that she also needs surgery. So, what about the wound, doctor? If she will get a scar or it will be disfiguring of the area of my daughter, she is still young.
Yeah. So regarding the scar, so basically there will going to be scar. However, the scar is going to be very small, about 4 centimeter. So because we are going to do open approach, then that means there's going to be scar definitely, but it won't be a big scar, and that shouldn't be a problem.
And
Except,
will she got?
Continue, please.
Yes, doctor. I was asking doctor that will she got any problem in future due to this one?
Okay, so like every other surgery, so appendectomy, that would be the procedure whereby the appendix is being removed, like what the one that your daughter is about to undergo. So this surgery also comes with its own risk. So and regarding your question, so in the future, your daughter might have after the surgery, there might be some kind of what we call adhesion when there's a scar at the site of the remover inside the tummy. So and this might lead to some fertility, in the future. But don't, because this can lead to blockage of the tube. Basically, every lady has 2 tubes, and and the one on the side. Hello, you want to say something?
Doctor, you told me that that means my daughter cannot get pregnant in future. Do you mean
Not
that?
at all. No, not at all. When I mean subfertility means
God.
let me just explain. So she's going to give birth. But what I'm saying is that she has got 2 tubes, one on the right and one on the left. So the appendix is located on the right. So the scar on the right inside the tummy might block the right tube. It might, it's not necessarily it's going to block it. So, but if that happens, the left tube is still very open and viable, which means she can still conceive perfectly. Do you understand
Doctor, who is? Yes, doctor. And who is going to operate my daughter, doctor?
Mr. Ladd.
Oh my God! Before my husband was also had some problem, and Mr. Ladd operated on him, and he died. I'm really afraid, doctor.
First of all, I'm so sorry to hear about your husband. However, if I may ask, regarding your husband condition, what happened to your husband, and what kind of operation
as I remember,
that was done?
As I remember, Mr. Labs did surgery on my husband. My husband had some cancer in the bowel. I can't remember that. And after the operation, only few weeks, maybe 5 or 6 weeks after, he died at home. So I think that it was the operation due to which he died. I'm really
I'm so sorry.
afraid.
I'm so sorry once again, and I understand that might be hard for you. But if I may say, with what you just told me, it's most unlikely that your husband died due to the complication of the surgery that was done by Mr. Ladd. And I can show you that Mr. Ladd is an excellent surgeon and one of the best in this hospital. And I can guarantee that your daughter is in a safe hand. And regarding your husband's condition, knowing that he suffered from a cancer, I most likely, he might have died due to a complication of cancer rather than the surgery that was performed on him.
Doctor, I want to see my daughter. I'm really feel bad. I want to see her. Can I see her right now?
Yeah, of course, I would like you to see her, but first I have to go and check if she has not been in the theater, because if she's in theater, I need to ask. That means you have to wait until after the operation. But if not, I will check and I'll get back to you.
Okay, doctor.
Do you have any other question that you would like to ask?
No, doctor. I'll ask if I will remember anything more.
Okay, so before I round up, so let me just go through what we've discussed. So basically, I've discussed your daughter's condition, that we very stabilized her, and we're about to move back to operation. And then Mr. Ladd is going to be the consultant. He's going to operate on your daughter. Okay, thank you for your time. And if you have any other question, please, you can go to the nurse and they will contact me. And I want you to know that we are here to help you and to support you. Thank you very much for your time.
Good.
Okay,
Excellent.
doctor.
Yes. Thank you, both of you. Right.
Thank
Good.
you, ma'am.
Excellent. Yes. Did you remember to say
very-
that you're leaving number with the nurse? And
Yes, he told.
Yes, he said.
Last.
Good. Very good. Yes.
It's very difficult to act like
Yes.
a weeping mother or grieve means.
In the exam,
she's in
actors get paid
guilt.
to do that,
Yeah,
and
they
they're
are
very
real
professional.
actors.
They're professionals.
Yes.
They get paid and they're repeatedly doing it, so it becomes natural for them. But it was quite
Yes.
natural for you as well. Like, we didn't feel
Okay,
as if you were, simulating. Good, excellent. Right.